So we are live now.
Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on the behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Dr. Prafulla Kerkar sir. Sir is Emeritus Professor at St. GS Medical College and KM Hospital, Mumbai, Consultant Interventional Cardiologist at Asian Heart Institute, Mumbai. Sir is former Guideline Committee Chairman of CSI Guidance Document on Acute MI HF Care during COVID. He is Chairman of Board of Studies at Maharashtra University of Health Sciences, former Chairman of Pinnacle India Registry in collaboration with ACC, former President of CSI Mumbai Chapter and organizer for CSI Con in 2018. He is investigator for landmark trials like CREATE, PREDICT, TAO, Paradigm HF, Paradise MI, SELECT, SCORED, Impact MI, ZEUS, and SURPASS CVOT. Sir is national leader for the Paradise MI and Surmount MMO trials. He has several hundred publications and presentations in national and international journals, meetings, and including prestigious orations and awards. Thank you, sir, for accepting our request to guide and support us as esteemed course director for this program. Our distinguished moderators, Dr. Girish Navsundi sir and Tabi Syed sir, are poised to share their knowledge, insight, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. Let me have honor to introduce our moderator, Dr. Girish Navsundi sir. Sir is Senior Interventional Cardiologist and Director Cath Lab, Apollo Hospital, Bangalore. He is first cardiologist to implant absorbed stent in private healthcare sector in Karnataka, first cardiologist to implant MRI compatible AICD system in Karnataka state, first cardiologist to implant tapering coronary stent in Karnataka. Sir has performed 5,000 angiograms and about 4,000 angioplasties, more than 50 TAVI procedures, and many PDA closures, ASD device closures, IVC filter deployment, and temporary pacemaker implantation. His special expertise is in complex coronary angioplasties, TAVI procedures, heart failure, and sudden cardiac death treatment. He has various publications in reputed journals. Thank you for joining, sir. Let me have honor to introduce our second moderator for today, Dr. Tabi Syed sir. Sir is interventional cardiologist at Lata Super Specialty Hospital and Topstar Hospital, Vijayawada. He is recipient of Dr. Kupachi Krishnamurthy Gold Medal in Medicine, performed more than 650 coronary angioplasties, including 150 complex PCIs independently so far. He has attended multiple international and national conferences, CMEs, and workshops. He has published over 32 articles, case reports in national and international peer-reviewed journals. He is reviewer of Asian Journal of Cardiology and Research, International Journal of Tropical Disease Health, Asian Journal of Advanced Research and Reports and Cardiology and Angiology. He is course designer, teacher, and examiner for BSc courses for cardiac technicians and PDF for echocardiography students. His special interests are interventional cardiology, heart failure, cardiac, and CPR awareness talks. Thank you, sir, for joining today.
Thank you.
Let me have honor to introduce our speaker for today, Dr. Sheetal Kumar Gatagat sir. Sir is interventional cardiologist at Vivekanand Hospital, Latur. Case he is presenting today is on multi-vessel PCI in single setting with difficult to cross stent. Thank you, sir, for joining. We have second speaker, Dr. Partho Chaudhary sir, who is Chief Consultant Cardiologist at Meditrina Hospital, Jamshedpur. Topic he is presenting today is complete revascularization in a case of acute myocardial infarction. I also would like to welcome Dr. Sachin Suryavanshi sir, Director Medical Affairs at Emcure, for joining today. And finally, I would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll start with opening remarks by our esteemed course director. This will be followed by the first case presentation by Dr. Sheetal Kumar, and it will be followed by the discussion amongst the faculty members. Second case will be presented by Dr. Partho Chaudhary, and it will be followed by a discussion amongst the faculty. In the end, we'll have concluding remarks by Dr. Prafulla Kerkar sir. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of cardiac diseases and interventional cardiology. I request our respected course director, Dr. Prafulla Kerkar sir, to share his opening remarks on today's topic. Over to you, sir. Sir, you are on mute.
Oh, sorry. Yeah. So, good evening to you all, delegates, as well as my co-faculty and the team Emcure. As already introduced by Dr. Rishikesh Shivale, this webinar series, courtesy Emcure Pharmaceuticals, has moved from COVID days when it was no thrombosis, because given their huge portfolio of anticoagulants and thrombolytics and etc., we used to, and I remember then Dr. Girish used to be a part of those seminars even then. Yeah. So now it's nice to know that it has become no thrombosis live in the sense that what we are going to do now is it could better be called, rather than KT live, KAT live, right? No atherothrombosis. So we are obviously looking at interventional cardiology here, and I'm joined in today by very top senior consultants out of Bangalore and Hyderabad who will be moderating the cases, and young dynamic interventional cardiologists from, one is from Latur and the other gentleman is from Jamshedpur. So having said that, today's theme, as we chose, is completeness of the revascularization. We all know completeness of the revascularization. Oops, sorry. Let me just decline that call. Yeah. Okay. So the completeness, the thing is, I have got WhatsApp also. I wonder if you guys heard the call that came in. I've got WhatsApp also on my laptop. Yeah. So having come back to completeness of revascularization, is all important. Completeness. It is very often the interventional cardiologists are criticized about doing only revascularization in areas where their balloons and stents reach, or their hardware reaches. But interventional cardiology today has grown leaps and bounds, and completeness of revascularization is obviously delivered by interventional cardiologists with the same efficiency that the surgeons would do, having opened up the chest and given their grafts. So completeness of revascularization is important not only in the acute coronary syndrome scenario, where of course we address the culprit artery, and then what about the 50% of the cases of acute coronary syndromes would have, in addition, uh, fairly significant lesions also in other arteries. So it has high as 50% the incidence of having that. And when to deal with them, how to deal with them becomes an issue, of course. And not only that, even in a chronic coronary syndrome scenario, completeness of revascularization to give entails a lot of complexities, and also like for instance, one of the speakers is going to speak in that scenario about how difficult it was to deliver a stent, and yet how he's managed to achieve completeness of revascularization. Why? Because not only are we talking in terms of preventing recurrent events in the future, recurrent revascularization for ischemia driven, that's what we are preventing, but we are also, by delivering completeness of the revascularization, preventing hard endpoints from occurring, that is reducing the incidence of further MIs, or for that matter, even giving survival benefit. So we could discuss all that together. And without much ado, let me give it over. I believe the program has changed, and Dr. Partho will first talk on a completeness of revascularization as to how we delivered it during an acute MI scenario. Over to you, Dr. Partho. Is that right? That's the order, right?
So we'll start with Dr. Shital Kumar sir's case first.
Okay, Shital, his is a case not in an acute coronary syndrome scenario, as
Yeah.
I understand.
His topic is on
Suppose difficult to deliver
multivessel PCI.
multivessel PCI. That's again, when you are handling multivessel PCI,
Yeah.
you are obviously delivering a complete revascularization. Go ahead, Dr. Shital.
Yes, sir. Thank you. Good evening, everybody, and I am very delighted to present my case here in front of such a renowned teacher who has always been inspiring for me. Today, I have a case of 56-year female who is 56 years, and she was diabetic, hypertensive, and no past cardiac history. Presently, she presented with exertional breathlessness. Her ECG was done. It was normal. Echo was normal with normal EF, no RWMA. And because she has exertional breathlessness and age 56, diabetic hypertensive, I felt that it is a cardiac origin breathlessness. So I asked her to get a angiography done. Angiography was done, which was showing LMCA normal. LED was long segment, 90% lesion in proximal mid distal segment. D1 was 90% lesion. LCX was mid 90% lesion, which was extending into OM. RCA was distal 90% lesion at crux, which was extending into PDA. Because the female was very reluctant to get the PTCA done, she did wanted bypass. So we did the PTC of this patient. I won't go to the angiography directly because I will go directly to CABG, PTCA, sorry. So before starting the PTCA, we had a TPI in situ for him, her, and 2 wires were put in RCA. As you can see, there was a distal lesion in the crux and which was extending into PDA. Then balloon dilatation of this artery was done at throughout the length of the PDA and at the crux with 1.5 balloon. And nextly, then a stent was brought in, which was of size of 2.5 into 38. And after balloon implantation, balloon dilatation, stent was implanted. At the distal end, we were not satisfied that the stent was properly placed. So we had first balloon dilated and then stent deployment was done. So this is the RCA stenting, distal RCA, and the stent was extended into PDA. So till RCA it was okay. This is the LCX. Selective engagement of LCX was done with the EBU 3.5. As you can see, there is a mid LCX lesion which is extending into the OM. So wire was crossed and balloon dilatation, and then stent was brought in. The stent was put across LCX to OM, and this is the balloon dilatation and stent deployment, as you can see. And after the stent implantation, you can see this was the result. Then real challenge occurred after we crossed the wire in the LED. As you can see, the LED is diffusely diseased from proximal segment to distal segment. And wire was crossed across the LED, and as we could see that we decided to put the stent from distal part of the LED from here till the proximal part. And we tried to check the scenes in aleocaudal also to have where the proximal landing zone is. And then we, after balloon dilatation, distal stent in the LED was brought, which was a size of around 2.5 into 33. Another wire was passed across the diagonal to have a support, and plus we had a plan to balloon dilate the osteoproximal part of the diagonal. So another wire was placed in position at D1 in D1, and distal stent was deployed after checking the proper position. Till this part, everything went fine. Then we measured the proximal mid-segment stent, what should be the size. Till that time, everything went fine. And we thought the osteoproximal segment of the diagonal should be dilated with the drug-eluting balloon. So magic touch balloon was used in this case, which was size of around 2.25 into 10. First stent was easily crossed. After this magic touch balloon dilatation, we tried to bring a mid-segment stent but it was so difficult to cross the stent. Here you can see it was so difficult to cross the stent that we had to use guideliner. A guideliner was brought in. There was a lot of haziness in the mid segment. We felt something is wrong here and there is a dissection here which is not allowing the stent to cross, or some calcium specks has come inside the lumen which is not allowing the stent to cross in. So we tried to dilate that segment with another 2.25 balloon. As you can see, there is a balloon brought at that segment, and a 2.25 balloon was brought in, and balloon dilation was tried. But we after that balloon dilatation, we took a stent of size of 2.75 into 30. As you can see, this stent was crossing till the proximal part of the first stent which was put in the LED, and few 10 millimeters gap was left, which was very difficult to cross. That stent was not crossing at all. After we found that we are helpless, we didn't have rota on the table, and our stent is not crossing. What we thought is, since we have pre-dilated the lesion with the balloon, I thought we'll put the stent in the proximal part of the LED. Anyways, we are not able to cross the mid segment with the stent. We'll first put the stent in the proximal part, and then with the help of the guideliner, we'll cross the proximal part, proximal stent, and then we'll put the stent in the distal mid segment of the LED. So this was the result after putting the stent in the proximal part. So this 10 millimeter segment we were not able to cross at all. Probably we had a calcium here inside and we didn't had the rota that time. So it was our thought that we will take now guideliner once again, and we'll try to cross the segment with that new stent. So after bringing in the guideliner, we first pre-dilated the lesion with this balloon, hoping that we will be able to again achieve and cross the stent. Once that balloon dilatation was done, we tried to bring in the guideliner and then we deployed the stent. So this was the stent. After the stent deployment in the mid segment of the LED, a stent size of around 2 mid segment stent was 2.75 into 15. So proximally 2.75 into uh, 3 stents were used, 33, then 30 millimeters, and then 15 millimeters. And side branch diagonal was dilated with the magic touch balloon. At the end, we could find, means we could get this final result in this patient. So in this case, what was very difficult was that we underestimated the calcium present in this case. Second is, first we deployed the distal part of the stent, then we had a magic touch dilatation of diagonal. Probably at this moment, whatever calcium was there at the branch of the diagonal, we have disturbed that, and then after that, the calcium didn't allow our stent to cross. So, so at this moment, I am saying that somehow we could use the guideliner and cross the middle segment of this vessel with another mid segment stent, and we could complete the procedure. Thank you. So this was.
That's a great case, meaning you have tackled so many. Now let's involve our experts who are there. Of course, you right at the outset mentioned that it was the individual preference of the patient that made you choose a multi-vessel PCI in a diabetic, a triple vessel with normal LV function. Herein, let me remind all audience as well as I share your opinion also, the moderators, that for a diabetic with a multi-vessel such diffuse disease, meaning theoretically at least, CABG takes preference over, with a normal LV function again, CABG takes preference over angioplasty. But if patient preference wise, otherwise, multivessel PCI in a diabetic, even in the latest of the guidelines, the 2024 European Society guidelines gives it a class 2A recommendation for improvement in symptoms. And herein, again, being a diabetic and this way, you have done all this. This is symptom improvement for sure that we are giving as a benefit to this patient. And as you mentioned very correctly, she has got class 3 symptom. That's as far as the indication for stenting in its multivessel PCI is concerned. The other thought process is, of course, the most important lesion in this TV CAD that the patient has as is the LAD diagonal and the diffuseness of the disease in LAD. And LAD we know is the artery that gives maximum angina, right? So having said that, that bifurcation lesion that you had, you chose to involve it as a provisional, it was not really provisional intention to treat, like it was a two device strategy rather than a two stent strategy. You chose a drug-eluting balloon for the side branch at an osteal location. But why not on the same count involve a drug-eluting balloon for the distal disease? That's where even it was not really a tackleable vessel for the surgeon. You would have had to do some kind of an endarterectomy to put the grafts therein. But as far as the ostium is concerned, hemodynamically, how much would you benefit just with balloon dilatation of an osteal lesion? So I have a couple of questions also, which of course the moderators, Dr. Girish, can start off with it. Firstly, you are now, of course, it's the no-brainer that we are all going to, because the patient has chosen to, you are going to do intervention. And since we are looking at intervention here, would you, for this diagonal of this size, okay, would you choose a two-stent strategy, or would you go for which 70 to 80% of the time we choose like a provisional stenting for the side branch? Now, this is a very important side branch, and how would you address it as far as the LAD tackling is concerned?
Uh, Thank you, Dr. Professor sir. See, if I were to deal with this patient, I don't know why that temporary pacemaker is there. Anyway,
Yes,
if
that's also a
uh,
very
yeah,
important point you
if
make.
if he was not a very stable patient, I wouldn't chase all of them at one go. If he had some bradycardia, hypertension, I think, call him back after 2 days, but during the same sitting. The first, if I were to treat, this is no, LAD was not very optimal vessel, distal LAD for a bypass. So you can contemplate a PCI, but then you need to give a good PCI and leaving a future option for a bypass. Now I think we have taken off his future option for a bypass by putting a distal LAD stent. I would never ever put a stent in the distal LAD. If I have to do 2 times, 3 times drug-eluting balloon, it's acceptable, but not putting a stent and then having total options closed. Because if he develops an ISR in the distal LAD, it's a graveyard that we'll be dealing with. Now, to begin with, if I were to see this patient and have a strategy, how to treat him, even the PDA is a future bypass location. And you've taken a long stent from distal RCA into the PDA. Probably it was good in 2020, but in 2025, when you have good to decent evidence emerging in drug-coated balloons, I would still consider doing a good modification of the plaque in the osteoproximal PDA with a cutting balloon, do an imaging, get a great lumen. And if it is satisfactory with less than 30% restenosis, I would just do a DCB. Like how we used a magic touch here, I would have probably used something like that in the osteoproximal PDA. That would have given a future option available to the patient. And we didn't have, I do not know whether the distal RCA stent proximal optimization has been sufficient. When I look at it, it slightly look undersized in the distal RCA, not optimized to 3.5. Coming to circumflex, I think it's a decent job done. Good job. I should appreciate you. But coming to the LAD, I would have done a good predilation like you did in the mid to distal LAD, and then wired both diagonal and LAD, and just across the proximal ostium part of the diagonal, I would have done a bifurcation here, either as a DCB in the diagonal and a stent in the LAD, provided it was done like a bifurcation, not like how it was done here. We just dilated the diagonal first, and then across the diagonal ostium, we post-dilated or pre-dilated multiple times, and that we cause significant narrowing of the diagonal ostium, which is much larger. No harm, you could have taken another wire, crossed into the diagonal, and done a simultaneous kissing in that diagonal LAD distally to have a good opening into the diagonal if you had already committed to a drug-eluting balloon. Otherwise, there is no harm even now to take a small stent as a T-stent, as a provisional stent, because it's not at all looking healthy in the ostium. Thirdly, to answer your challenge, why did your first stent into the distal LAD crossed without any resistance across the mid LAD? So what was restricting you from taking the proximal stent to overlap the distal stent was not the calcium in the mid LAD, but the drug-eluting that balloon that you chose to do the diagonal ostium may have either deformed the distal stent, or it must have changed the vessel morphology. If I were to cross the, another stent to overlap this, I would have done a very good post-dilatation of the distal LAD stent, and I am sure it would have crossed, in my opinion. If I were to do the diagonal ostium while having two wires in LAD and diagonal, I would have kept another balloon in the distal LAD stent, and while doing the ostial diagonal DCB, I would pull this balloon back and do a simultaneous kissing that will permit my second stent to enter. I think I conclude here.
Yeah.
Okay, now Dr. Syed, would you be inclined to do bifurcations of this kind? And if so, do you at all use imaging? Like, very importantly here, what point that Dr. Girish made is that to give a good result, and also keep the option of CABG for the future. Today she was not willing. When she later stage, when she has to undergo a second procedure due to restenosis, maybe then she might be willing. So from that point of view, would you like to have a good result and use imaging? And if so, how would you go about in this particular case?
Thank you, sir. Thanks so much. And Dr. Pardo, depending upon his resource settings, I think he has done a commendable job.
Yes,
And of course. And CABG, sir, most of the surgeons now are hesitant to do endarterectomy. Whenever they say distal LAD diffuse disease, they are slightly saying keep on medical management. Now, trend is like that nowadays, at least in the second tier cities. In top tier cities, Mumbai, Hyderabad, it's okay. They are okay with endarterectomy and going ahead. But tier 2 cities, still, especially the Yojana patients, they are not at all touching the distal endarterectomy patients. Now, for LAD, definitely, sir, imaging would have definitely helped. As he has used Magic Touch, we would have used that income resource for imaging. It would have given a good result for him in at least for LAD, because as you said, it's LAD that caused most of her symptoms. And post-dilatation would have helped, and he would have got a very good idea what was happening across the diagonal if imaging would have done.
Yes.
In this case, at least if imaging was done, mostly that Magic Touch or DEB would have not been necessary. Would have straight away did direct provisional stenting. If necessary, we would have just rewired and just opened the strut, or would have left like that. And here, Dr. Pardo is lucky that after the middle stent, the diagonal was not closed. He is lucky here, because I thought after the dissection, after doing the third stent, definitely diagonal would have gone there. He is lucky here, he escaped here. And Dr. Pardo, some learning points for both of us, because we are still young cardiologists here. And I don't understand still, as Girish sir pointed out, why TPI in this case. Normal LA function, not much calcium, and this is not acute MI. And you said ECG is normal, no AV blocks, nothing. Why TPI? Maybe you are slightly hesitant because multivessel PCI. You are anticipating any events, that's why you have gone. But
Yes.
but still, TPA was not so indicated in this case. This is first
TPI
part.
gives a, may I add here, TPI gives a false sense of security to the interventional cardiologist. I don't think TPI is that way. Preventive TPIs save lives. There is no data on that. Again, we used to, because I trained good old days in 1995 in a rotablation center in Germany, where even those days stents had just come into being. And we used to, when we were a part of a trial, which was the airbag trial, Excimer plus rotablation plus this. And I was quite shocked to see that even a RCA rotablation would happen without even the, you know, without a TPI. So that's what there would be. Just they used to save on costs even in Germany. Just keep a vein access. That's about all, but not even a temporary wire, because temporary wire does more harm than otherwise. That is what it is. And both of you experts would agree that from a futuristic point of view, now this thing about both of you seem to be okay with the fact that a duck coated balloon is being used in an ostial location in a diagonal. I think that we are extending it a little too far. When we are diffuse disease, to tackle with a drug coated balloon is still okay according to me, but an ostial is an area where hemodynamically making a drug coated balloon result good. From that point of view, would you ever look at why putting in an FFR wire down the diagonal after having stented the main branch?
Yes, sir, I would have definitely done that, sir. I would have
Yeah,
gone for provisional stenting. If at all some hemodynamics would have compromised, then I would have gone for any cross.
exactly. Yeah. At the
Sir.
most, an FFR wire down the diagonal may have been good. Excellent case. However, Dr. Sheetal, you were good. And in hindsight, just a single stent across the most important bifurcation lesion, just one layer there and no overlap there, is a good idea again, though it happened accidentally, but that's still a
Yes.
good idea, just a short stent at that area. Okay,
Yes.
and all agree that imaging would have helped us deliver maybe from a futuristic point of view also a better result and a more definitive result in terms of not getting restenosis. We would be happy to at some point in time know what is the outcome in the future for this patient. Thank you so much, Sheetal. Excellent
Thank you,
case.
sir.
Yeah.
Thank
And
you,
now
sir.
let's move over to Dr. Partho for him addressing complete revascularization just the way he's done it in a chronic stable setting, but you doing it in an acute MI setting. Over to you, Dr. Partho.
Thank you very much. Sir, are you able to see my slides?
Not yet. You
No,
have
sir.
the share screen option and
You can click on the share screen option, sir,
Okay.
at the bottom. And then
Sure, sir.
uh, we can see some browser, but you can click on the slide. You can share slides.
Now
Now
you
we
can
can.
see?
Yes, sir. Yes, sir. Can you make it full screen?
Yes,
Yeah,
yes.
yeah. Now we can see, sir.
Sir, as you know, a topic of today's presentation was management of multi-vessel disease during STMMA, culprit vessel or complete revascularization. I will share few of my cases that I have experienced, sir. So, as CAD prevalence is increasing, now we are encountering at least 50% cases of primary angioplasty. Those they are having multi-vessel disease. Now, the dilemma is whether we have to do the index PCI or stage PCI. And many patient came to us with shock whether we have to do single or multi-vessel PCI. Then we often encounter complex multi-vessel disease with PAMI. Then problem arises because we have not that guidelines did not included such type of cases. Many of the cases will have underlying left main heart failure, CTO, cases with high syntax score. This is another dilemma. And fourth is like, what should be the time after PAMI when you are trying to do when you are doing a multivessel disease? Now, sir, not coming to guidelines, I'm just directly coming to my cases. I have two cases. I'm sharing one by one. This case is a 40-year male who came to us with severe breathlessness from last 24 hours. ECG, there was small Q wave with ST elevation in 2-3 AVF. Echo, it was global hypokinesia with severe LV dysfunction. Anti-proBNP TROP-T was raised. He was put on NORAD and severe tachycardia, and BP was like 90/60, and he was on BiPAP. Such patient was immediately taken to for angiogram, and this is his LMCA. You can see LED is 100% occluded, as well as L6 ostium is also diseased. Now this is the RCA. RCA itself is 100% occluded. So basically, this case was having, though it was inferior MI, it LED and RCA both were 100% occluded. So first, what we thought it is definitely inferior wall MI, with there must be some collaterals from RCA to LED. So it must be having LED CTO. So since it is inferior wall MI, RCA is occluded. That's why LED is also appeared to be occluded. So in this case, PAMI to RCA will work. But the thing is, rarely few cases has been reported where there is where they have seen sometimes there is simultaneous occlusion of a double vessel. So it is a rare chance. It may that there could be a simultaneous occlusion of RC and LED. If this is the scenario, then we have to do both. Then we decided then since the patient is in cardiogenic shock, but if this is the scenario, then we will do the PAMI of both LED and RCA. So first we approached RCA. So with balloon dilatation, that RCA proximal to it, there was a long lesion, and after balloon dilatation, we put a 3.5 into 38 stent, and we achieved timithrone RCA. Next, the thing is from RCA, since there was no collaterals to LED, so in this case, there should be a simultaneous occlusion of both LED and RCA. So we decided to do PAMI of LED also. And after dilatation, this LED also, we have a good flow. And after balloon dilatation, we put a stent in LED of about 3 into 23 mm size. So in LED also, there was a TIMI3 flow. And from this case, what we can conclude is though simultaneous occlusion of two arteries in STMI is rare, though it could be fatal. Here, coagulation profile was normal. There was no retrograde collaterals from RCA. So it proved it was simultaneously, or probably RCA plaque ruptured first, as there were inferior wall MI ECG changes. So contrary to usual approach, here we did PAMI of both RC and LED, though the patient is in cardiogenic shock. Sir, second case I'm sharing. This is a case of 80-year male who late presented to us with anterior wall MI with severe heart failure. Patient was kept on maximum diuretics, BiPAP, vasodilators. He was on intractable heart failure, and we were not able to wean it. The patient was having evolved anterior wall MI. Echo was showing a severe LV dysfunction, and one important point was he was on stage 4 CKD. Now, just presenting the NG of that patient. That patient is, this is the RCA CT of the patient. Here you can see a long CTO with an ambiguous cap with collaterals arising from LED. And this is the LED lesion. So LED lesion was a simple lesion with typical TIMI3 flow in LED. So in this case, how we could approach this patient, this was refused by CT-based surgeon because of 3 reasons. First is LED territory was only partially viable. He was stage CKD. And thirdly, distal RCA, it was diffusely diseased and it was not suitable for graft. How we approach in this case, we decided since he was having CKD, we have to do the case with minimal dye. First, we'll approach RCA, that is retrogradely. And if we fail, we'll just do a PTC of LED because it supplies collateral to RCA. It may work. So in this case, we decided to do a RCA plasty with retrograde approach. Now, we all know there are certain steps in while we do a CTO. First, we have to choose the collaterals. This. So, if you see carefully, sir, there are so if you see carefully, we have excellent collaterals with clear-cut obtuse entry angle. There were minimal branches and that is clear connection to RCA. So we have decided to use this second number of collaterals, that second number collateral that I'm pointing for retrograde approach. Sir, for crossing, we use usual wire, that is a 5-cross microcatheter along with Sion black. We have crossed the collaterals. Wire was on the RCA. Third step is always to check whether it is in true lumen or not. So this view show that our wire is a clearly true lumen and it is in a probably acute marginal branch in RCA. Next step is to puncture the distal gap. For this, we keeping the microcatheter, we change it to Gaia second wire. And with the help of it, we have punctured the proximal cap and we took the wire to the right catheter. Next step is trapping the wire with the help of a balloon that we did, and we took the microcatheter to JR. Now the things are easy. We changed to RJ3 wire, and after that balloon dilatation followed by 3.5 into 48 Zine stent was put. And last step is always carefully remove the RG3 wire with a cover of microcatheter. Lastly, this was the result. So what we can conclude is there is not very well-defined clear-cut guidelines for treating multivessel disease in PAMI because most of these recent trials, they have not included all the type of cases, especially complicated cases, those having high syntax score, LMCA, CTO, and what conclusions they have drawn for these guidelines were for simple lesions where we can, in stable patients, where we can do culprit artery followed by either we do in the same sitting or in the subsequent sitting. The benefit of doing same sitting is there is a reduced unplanned revascularization. So it is the clinician or heart team, if available, only they can decide the right approach as per the cases. Thank you very much.
Well, thank you, Dr. Partho. Excellent cases, both of them. And though exactly not what primary PCI as we call it in the strict sense of the word in terms of time frame, etc. The second case was obviously a very delayed presentation of, I mean, not necessarily a primary PCI that way, correct? They were troponin elevation, he was heart failure, etc. Even the first case was excellent. It was that you presented wide range of ages there. A 40-year-old where you would want to do something, and at the other extreme age is the 80-year-old gentleman who is in heart failure and of course has got a doable LAD lesion and has got a CTO of the RCA, which you very rightly staged. And you also pointed out during your presentation the important thing about the jury is still out in terms of how do we address the multivessel disease in a primary PCI scenario as well. Okay, leave alone this. There is a unanimity about completeness of revascularization is important even in an ACS scenario. It may be staged up to 45 days is what they talk about on the basis of the complete trial, which came somewhere in the 20s,
Recently.
early 20s to 2019 or thereabouts. So that is the main thing, and that is what they rely upon for evidence even today, though all that is there about this. And the preference in the absence of cardiogenic shock and clearly a patient that deserves on the basis of the non-culprit anatomy, complexity of the case and all, CABG is still an option. Cardiogenic shock is a class 3 indication in the latest guidelines also as far as addressing multivessel PCI in a scenario of primary PCI is concerned. That is there. And then again, the staging wise, generally one would prefer to do it at the same stage, and unless it is something as complex as what you had, which you obviously in the 80-year-old staged it. So having said all this, would you address now, Dr. Syed first, would you address the second patient in any different way? That what do you think was a culprit here to have precipitated that heart failure? And was there really a need to go after the RCA CTO? And if so, how would you go about it in any different way than what Dr. Partho chose to do? Yeah. So would you otherwise just be incomplete here, just do the LAD, and CTOs are anyway long drawn out people and he is any which case 80-year-old. Would you be play out of the guidelines and just leave him alone after having done this, given the CKD status of the patient? We forgot to ask you how was his contrast.
That is why, sir, since we did retrograde, you can see hardly 30 to 40 ml dye we did.
Great.
So that's
That's
why
great.
That's
Very,
why we
very
approach
important.
retrogradely. Because in
Very,
retrograde there would hardly be 20 to 30 ml dye. If we would
yeah,
have done antigrade, I wouldn't have done antigradely because it would be a mess. So that's why I did
absolutely.
retrogradely.
So for the benefit of the audience, we need to look at the contrast load very much when it comes to in a primary PCI setting, right? And that is what it is. So you might be willing to stage it in the primary PCI setting also from that point of view. So the unfavorable factors that come into picture, and of course, when it's primary PCI, something like that, if it came as a primary PCI with an LAD as the culprit out here, obviously you would just deal with the culprit. The message would be that, right? And you will stage the RCA PCA at a later date
So
because of
actually problem was LED was very good flow. It was almost TME3 flow and LED lesion was not looking so much tight that putting a stent would be beneficial for the patient. That is the only reason. And if I
yeah.
would have failed, then I would have put a LED. Let's see what happened. So that
Okay.
was
Oh, you haven't
that's
stented
what.
the LED at all. I was
LED.
sorry.
LED, sir,
Uh,
you look, it doesn't look like a very significant lesion.
Okay, so
So
you haven't addressed the
why?
LED at all.
So I
I
did
didn't.
RCA, then I put LED, but I thought but the only LED won't work because there is a TME3 flow and the lesion was looking just 80 to 90% clean cut lesion. Why the patient will have so intractable heart failure? That was like my view in this.
Great. Yeah, Dr. Syed, your comments on this, please. Yeah.
Sir, case was fantastic, but my opinion will be completely opposite. I am in line with you, sir. 80-year-old antivalamide, definitely I'm not going to touch CTO, whatever it may be. In addition to that, CKD stage 4, suppose if you will not put stops the next day, you will be in a mess.
No,
So
no,
that
see,
definitely,
no. The thing is, CTO requires less dye as compared to routine procedure.
okay,
So that is a misconcept. When you are doing retrograde CTO, you will require hardly 20 ml dye. If you it require less dye. That is why it was approached retrogradely. Since creatinine was raised, that why it was approached retrogradely. Otherwise, if I have to do anterogradely, I would never do. I would never do. That
now
is why we approach retrogradely.
That's okay.
Yeah, because you had good retrograde collaterals and all that. So you
That's why I
approached.
approached. Otherwise, I would never approach anterogradely. It would be a mess.
Yeah,
The benefit of doing
Yeah, Dr. Girish, you have any alternative ways of dealing with the 80-year-old? There is no question you did a commendable job on the 40-year-old. Only the 80-year-old, of course, you're showing us a very good case done, very well done. You're showing it. Would you have approached in any other way in terms of management for an 80-year-old with, did he present, you said, with anterior MI of some
anti-AVL
good
MI with severe heart failure.
severe heart failure? So would you have
think
approached in any other way?
I think 80-year-old, I would probably look at him like a high bleeding risk category. I will try and keep as few stents as possible. Try and use wherever feasible a drug-eluting balloon. Sir, honestly, if you compare the data, compared to angioplasty with plain balloon from 1970s or I'm sorry, 1975 to 80s to now, with a third generation drug-eluting stent, there is no reduction in death. It's only reduction in the event rates and restenosis, that is angina, myocardial infarction, and what do you call the reduction that ISR. These are three things that we have decreased. So whenever we have an elderly, probability of a bleeding risk, and try to be as minimalistic as possible. And balloons will become, as I see coming days, more preferred choice, and stents will become for wherever there is, after plaque modification, significant residual stenosis, uh, dissections, or less than TIMI3 flow. I think that is where you will have to implant a stent. For an 80-year-old man, stent and balloon does not make much difference. But I would still try and keep stents to minimum possible. That would be my approach.
Yes, so that is very good. Now the important thing is that we are all interventionists here. We are used to
Stent.
look at stented results. So
Yeah.
good old days, I remember having written an editorial on a stent-like angioplasty. Okay, balloon angioplasty. We grew up in days of POBAP to begin with, and then bare metal stent versus an angioplasty, a stent-like angioplasty. Okay, if you get a good balloon result. So what is your threshold about putting in a doing a drug-eluting balloon first, and then what kind of a result do you accept? From
Yeah.
the one count, a little dissection is a known mechanism of balloon angioplasty for relief of the stenosis.
Yes.
But when do you come in spite of a drug-eluting balloon
A
with a
stent.
stent?
Yeah,
Yeah.
great. I think it's a great question. See, the mechanism of gaining lumen, angioplasty, is creating a controlled dissection. You can never expand the vessel without dissecting the segment that is diseased. But as long as you have a nice controlled dissection, we have to learn now trying to do good balloon angioplasties. Stent, I think, no brainer. Even a technician can implant a stent. I think we have to learn to do a good angioplasty where you get a good plaque modification and a minimum lumen diameters which are more than 4 or 4.5 millimeter squares, and have less than 20 to 30% residual stenosis with your good balloon dilatations. If you achieve that without major dissections and TIMI3 flow and no contrast staining in the treated segments, we are very safe leaving behind. Unfortunately, most of young people have been scared of seeing a dissection, stent edge dissection, distal, proximal, or put one more stent and come out. That's good for the immediate outcome. But when you look at a long-term outcome, we all know that stent failure is the greatest problem that we have to deal with as we go forward. So for me, the threshold to put in even in a diffuse lesion, I start doing like the previous case. The first case, they showed 1.5 millimeter balloon, 2 millimeter balloons, preferably NC longer balloons, so that you get uniform expansion of the lumen without causing multiple edge dissections of shorter balloons. If you take a 12 millimeter balloon and dilate 3-4 times, end of that each balloon proximal segment, you would have caused a dissection, and you will cover with another dilatation. End of the procedure, you will have multiple dissection in that disease segment. Rather, I choose a 220 long NC balloon, go at a 6 atmosphere, see under stent boost whether it's completely open. If not, go at 8 atmosphere, keep for 20-30 seconds. If it gives you nice, good expansion, no significant residual stenosis, then I go with a drug-eluting balloon. I do not do drug-eluting balloon and then see for whether there's a recoil or a dissection. Use a long balloons, get a nice TIMI-3 flow with less than 20% residual, 20-30% residual stenosis, no major dissection, then take the DCB, do the thing and come back. Sometime, in spite of this, there is going to be TIMI-2 flow, there's going to be a larger in-between dissection, then spot stenting I shall do within the healthy segments. It could be 12 millimeter, 15 millimeter stent. Again, the data is lacking here because you're delivering 2 doses of drugs, one through the balloon and then second through the stent. I think it becomes overdosage. We do not have much data at this point in time. But when I listen to Kukuli, who's from Switzerland, he says, don't bother. Just balloon come back, vessel heals in 6 weeks. Go and do the check angiogram. If there's no ST elevations on the table or in the immediate aftermath, TIMI-3 flow, even a significant dissection, leave it. Call him in the morning if you think there are ST elevations. If there are no ST elevations, leave him alone, call him back in 6 weeks and do the angiogram. That's my strategy, sir.
Yes. So you would image always, is it?
Yes, because the plaque modification is the key if you're not going to put a stent. If it is
Exactly.
a severely fibrotic lesion, you need to use a cutting balloon. NC balloons are not going to give you. So you need a Wolverine where you need a controlled dissection of the vessel without causing hematoma. What happens?
Right.
Most people use a just NC balloon, go at a high pressure. The shoulders will dissect. And in the center, it may recoil significantly. I think we have to learn to modify the plaques very well. Next,
Exactly.
if you have a calcified lesion, I will use liberally ablative therapy, either rotablation or orbital, debulk as much as possible, and
And
then
then
do a
come in.
come in with that.
Yeah, so these are all very well taken points. I think we are overshot our time. Yeah. So we should wind up, I guess. And the thing is that the second case, the second presentation in an acute scenario, what the speaker also pointed out, Dr. Partho also pointed out, the jury is still out as to you must individualize decisions. In both the cases, we saw that the decision was individualized based on the needs and preferences of the patient. But having said that, in the first case, I would remind the delegates out here attending too, that when it is that kind of a disease, it is with a normal LV function, diabetic and all that. Though we are in an interventional meeting, we must not forget that CABG still has it has a role to play, because we cannot forget that just as we have advanced, the surgeons have also advanced in their techniques, and beating heart surgery, at least in a city like Mumbai, is the norm. Although Dr. Syed alluded to the point that endarterectomies, etc., in a scenario where the finances are lacking, the surgeon wouldn't spend that much time on that case, or whatever it be. But from an academic point of view, one must not forget that even today, good old Barry alert came some 15-20 years ago about diabetics, but that alert still remains with normal LV function and a diabetic multivessel PCI. Surgeon has a role. We must not forget that. That is one aspect of the first case. Then, of course, the difficulties and the nuances as to how do you approach. And I would also add one more point to the difficulty in putting in a long stent versus a well dilated proximal segment, and then coming in with a short stent works. And a short stent would still work at that important place, meaning we always did that. Howsoever flexible and great designs, expeditions, etc., have become, but longer stents to bring in versus a shorter stent to bring in is always different in terms of this thing. So that was good learning from the first case about the role of a guideliner in a difficult stenting area. And Dr. Sheetal Kumar, in spite of all that, did get away with not an ideal result necessarily in the osteal diagonal, and he will obviously follow on that patient to see as to whether there is any recurrence coming up. But yes, all the three lesions tackled well. Now, the second case, as what we mentioned, how to go about addressing the non-culprit lesion. We were not sure which was the culprit in either patients, or more so in a second patient, the non-culprit, very correctly so, was addressed with good planning, and also taking into account the unfavorable scenarios for the non-culprit lesion. Number one is that in a cardiogenic shock state, do not address the culprit lesion unless it was something like the Dr. Partho's first case in a cardiogenic shock. Do not go for it. Again, like this 80-year-old gentleman, if it was not a clearly doable CTO, that he was able to, he was confident he was able to offer a complete revascularization, and therefore to do a non-culprit lesion, the RCA as well is point very well taken, but we need to remember that. And in a true primary PCI scenario, of course, he's looked at the contrast nephropathy part of it, the other complexity adding to it. In a true scenario where true primary PCI, where times is at a constraint, you may not even be aware of the patient's creatinine, and the labs are ordered, and by the time you completed the procedure, you come to know. So you know the contrast load that you have to give in terms of the next lesion, the non-culprit lesion, how do you address it? And finally, of course, one cannot forget in all that the costs when you address the extra lesion at the time of the thing. I wonder how it is in other institute settings, but what happens in certain institutes when you come back for a staged PCI in a culprit vessel in a complete revascularization scenario, if you do it at the same admission, at least my hospital does not charge extra for the second PCI. That is what we have got it sanctioned from the hospital administrators, but otherwise it adds to the procedural cost. Besides, of course, doing it, the preference should be to address, if they are doable lesions, the non-culprit at the same time is what it is. Everybody agrees upon that, that you can address it at the same setting, or even if you come at a stage setting, within the first 45 days, basis the complete trial, you must address the lesions to prevent recurrence, not only in the lesions, but event rates in the other non-culprit vessels. That is there. So with that, we also today, thanks to Girish, Dr. Girish also, and also the fact that Dr. Sheetal had used a drug-eluting balloon, maybe on the basis of what Dr. Syed believes, and even I believe, not necessarily for the osteal lesion. I would reserve it for, I would have in that case done it for the distal LAD rather, where the surgeon anyway would have not grafted, or for that matter, as Dr. Girish pointed out, to the RCA itself, one could have used the drug-coated balloon. And the importance of drug-coated balloon today, the whole cycle has changed again, isn't it? We became stentoplasters, and from that, again, there is a new school of thought wherein drug-coated balloon will match, just deliver the drug there and no stent, though Dr. Girish Navasundi has been the first primary user of the Absorb. We saw the Absorb fiasco, what has happened. So despite the disappearing stent, and try and not give maximum metal and do a good modification of the lesion and continue to compete with the surgeons, or rather in the interest of the patient, do the good kind of a complete revascularization even in multivessel PCR. With those few words, unless my co-faculty wants to add on something, I hand it over to Dr. Rishikesh Shivale.
Thank you.
Okay. Thank you, sir, for the concluding remarks. So we are nearly...
Excellent presentations by both our dynamic young cardiologists.
Yeah, we are nearly at the finish line, but before we conclude, let's express our gratitude to all who made this scientific program possible. I would like to express my sincere gratitude to our respected course director, Dr. Prafulla Kerkar sir, and our distinguished moderators, Dr. Girish Nausundi sir and Dr. Tabish Sayed sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Shital Kumar Gatagat sir and Dr. Partho Chaudhary sir for their insightful case presentations. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time, continued love and support for this No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you. Thank you.
Thank you.
Good day, Dr.
Thank you,
Prabhu.
sir. Thank you.
Good day, Girish. Bye, Dr.
Thank you.
Syed.
Thank you,
Bye.
sir.
Thank you, sir. Thank you.